Again, I want to thank Robin Adams, Brian, Linda from ICUS. We're going to start in about 30 seconds. All righty. Well, again, thank you all who have joined us. We look forward to this morning's discussion. We're going to talk about myocardial perfusion contrast-enhanced echo, when, how, and why it matters. And it does. This is a brief introduction. I'm Steve Feinstein, and the disclosures are listed here. And let me say that all other reviewers, planners, and faculty have disclosed no relevant financial relationships, and all conflicts have been resolved. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through joint providership of the Illinois State Medical Society and the ICUS Group. The Illinois State Medical Society is accredited by ACCME to provide CME. The Illinois State Society designates this live activity for a maximum of 2 Category 1 credits, and you should claim credit really only for the commensurate part of the extent of your participation. How do you get your CME certificate? Watch for an email, fill it out, send it promptly back to us. CME certificates will be emailed and to registered participants upon verification of the completion of this program. If you don't receive it within 30 days, please contact Evelyn Calhoun at the email listed here. Wonderful faculty, world-class experts, great friends, great colleagues, and tremendous knowledge base. I think that this is a wonderful, focused activity on myocardial perfusion with contrast echo. Great subject. I want to welcome everyone on behalf of ICUS. And today's agenda, as you can see, we'll begin roughly at 10. We'll conclude around 11:55. There'll be question and answers. I'm sure it'll go on as the topic is quite exciting. But submit your questions and comments throughout the program, and we'll respond at the end of the session. On behalf of ICUS, I want to welcome everyone. What is ICUS? It's the only professional medical society that is exclusively devoted to promoting the safe and appropriate use of contrast-enhanced echo to improve patient care worldwide. What do we offer? Free CME education, live programs, archived webinars, and a weekly news monitor and newsletter, now in English, Mandarin, Portuguese, and Spanish. We have a very comprehensive website with free resources and archived webinars. And what do? We advocate for appropriate CEUS labeling and payment. Our membership is free. Please join us at the website, www.icus-society.org. And we are committed to education, as evidenced from today's seminar. You're going to appreciate world-renowned faculty. We'll discuss appropriate and off-label uses that improve patient care, practical skills for both novices and experts. We offer online and in-person programs that offer convenience, safety, and quality, as today's example. We've trained over 1,700 professionals so far. And again, please visit our website for further information. I want to thank you all. I look very much forward to the seminar. I want to hand off to my good friend, Dr. Andy Eppes. Thank you.
All right. Let me just get set up here. Steve, can you see my screen?
I can see your screen, yes. And if you go into presentation mode, I think you're there. That's beautiful.
All right. Very good. Thanks, Steve. Hello to everyone, and good morning to my fellow West Coasters. My name is Andy Apis, and I am a physician lead and director of the Echo Lab here at Permanente San Diego. We are a large echo lab. We do over about 100 studies on a daily basis, and I've been fortunate to be in this leadership position in our group, and I consider it an honor that I'm starting to help our echo lab grow in both volume and technologic advances. I had the good fortune of training under Steve's mentorship in Chicago. I was there. I got to see the firsthand passion that so many of these true clinical scientists like Steve and Tom Porter had for microbubbles. And it really sparked my own personal interest as well. As I've grown in my career, I've been very thankful they've allowed me to participate with ICUS. And so a few months ago, we were discussing some of the educational program for ICUS. I brought it up to Steve and Linda that while our talks towards the general concepts and ultrasound enhancement are great, it would be fantastic that we have a talk specifically directed to mastering the art of contrast perfusion. And so here we are today. We're going to talk about perfusion with one of the leading experts of the field, Tom Porter, and his outstanding lead sonographer, John Olson. And we're all very excited to hear what they have to say. But to start off our series of discussions, I'm going to spend a few minutes reviewing myocardial contrast echocardiography. And so myocardial contrast echocardiography is a non-invasive imaging tool that allows us to get a detailed assessment of the coronary circulation. To perform myocardial contrast echocardiography, we utilize gas-filled microbubbles referred to as ultrasound enhancement agents, or the old nomenclature, as many people still use, ultrasound contrast. On a side note, ASE guidelines recommend we avoid using the term ultrasound contrast, as patients can associate this with iodinated contrast that is used in angiograms or CT scans. We just want to make sure that we are clear on this point so our patients are not inappropriately concerned about potential risks of these agents, such as effect on the kidneys or allergies to iodine shellfish. Ultrasound enhancement agents, or UEAs, remain entirely in the intravascular space, and their flow patterns are similar to the hemodynamic response that a red blood cell would have. During an IV infusion of the microbubbles, and after we've attained a steady state of the bubbles in the blood, then we destroy these microbubbles with a high-energy ultrasound wave. The subsequent rate at which the microbubbles then replenish the myocardium allows us to quantify or qualify myocardial blood flow. And so why or what are the driving factors behind the concept of myocardial contrast echocardiography? Well, the concept of ultrasound enhancement agents have been around for over 50 years now. The idea that a gas-filled microbubble could improve ultrasound and specifically help to better visualize or assess LV function has been known for quite some time. But the unique property of the strictly intravascular nature of these bubbles is really kind of what got people thinking and why we're here today. Now, we all know that coronary angiography is considered to be the gold standard to evaluate the severity and extent of epicardial coronary artery disease. And yet, as our experience with coronary angiography grew, we immediately began to see cases in which a patient would come in with the clinical signs or symptoms of a heart attack, and yet when the angiogram would be performed, the epicardial arteries would not show the expected severe obstructive lesion. Or we'd encounter other scenarios in which you would image the epicardial arteries and there would be no significant blockage in the epicardial arteries, but yet flow down the arteries would be extremely sluggish. And it's these situations that got clinical cardiologists that we encounter on a daily basis that tell us that the epicardial coronary arteries only really tell us part of the story. And it's really changed the paradigm in which we think of coronary artery disease, and it's allowed us to begin to understand that we needed ways to better assess the function of the coronary microcirculation. And so this is a great slide, great reminder to all of us that the coronary microcirculation is so extensive and vast, and it is truly how we get the blood and oxygen to the heart muscle. But yet so much of our daily practice as clinical cardiologists is really focused or geared towards epicardial obstruction. And so we often forget this. And this is obviously a double catheter in both the right and left coronary arteries that we see. I'll use my laser pointer here, so the right and left coronary arteries. But when you zoom in, you see on these magnified images just the extensive microvasculature, the arterioles, the capillaries that go into making the full circulation of the coronary arteries. And so the initial concept of myocardial contrast echocardiography began in the early 1980s. Innovators in the field frequently found themselves working
I think Andy's taking a little break here with some computer glitches. I think we'll wait for just a couple minutes, see if he can come back in. When he does, he'll take over. There we go. Good to see you back, Andy.
Can you hear me?
Yes, you're back.
Okay. I think my connection must be poor. So give me just 1 second. Let me fire back up here. Get back on my screen. Steve, can you see that?
Not seeing the screen shared yet. We liked your introduction, though. Nice introduction. I like the physiology. It looked great. It's a good setup for Tom and Joan. And you're right, Andy. We spend all our time looking at the epicardial vessels when the vast majority of the blood flow of the heart, it's not in the epicardial vessels. It's in the microvasculature.
Okay. Can you see now?
We don't see your screen set yet.
We have you in good, but we don't have the image, the screen.
I think it's coming.
Okay.
There it is. We're back.
Okay. Perfect. All right, very good. So, sorry about that. And so, the initial, as I was saying, the initial concept of myocardial, let me get rid of this. The initial concept of myocardial contrast echocardiography really began in the early 1980s. So innovators in the field like Dr. Feinstein showed that injecting ultrasound enhancement agents down the coronaries and then assessing their response via echo was kind of the initial way that we began to look at that inside of the cath lab. Subsequently, others began to look at different aspects of myocardial contrast echoes, such as the relationship of the flow of microbubbles as compared to red blood cells in the capillaries. And that was done in, kind of the initial studies by Jay Weir et al. And Call et al. And what we found was that ultrasound enhancement agents did, in fact, have similar blood flow to that of coronary flow to that of red blood cells. And this is a very integral part into perfusion imaging because it allows us to use microbubbles as a marker or allow us to assess coronary microvascular flow. And so with all this processing or with all this progress in scientific studies showing, this ability to assess coronary microcirculation, we found that aspect was growing, but the rate limiting piece was the technology. And so the crucial technical advance in myocardial contrast echo was the development of on-cart ultrasound signal processing. And so to understand this, we really need to understand some of the basics of the physics of ultrasound enhancement agents. I'm going to base on that here for a few seconds. So first, unlike tissue, microbubbles or ultrasound enhancement agents are compressible and they will oscillate in an ultrasound field. At extremely low mechanical indices, these bubbles will oscillate or reflect ultrasound waves in a linear fashion. Now, in low, and what we consider to be low and sometimes very low mechanical indices, these oscillations become nonlinear. And so what that means is during each oscillation of the ultrasound wave, the bubbles will expand and they will contract, and oftentimes they will expand more than they contract. And that reflective ultrasound wave from the bubble back to the ultrasound probe comes back at a different frequency than the signal that was sent, which we often refer to as the harmonic. This is what we call nonlinear reflection. And so with the use of novel signal processing techniques, these nonlinear signals can be amplified and linear signals from tissue can be suppressed. And this allows us to get these perfusion images that you will see throughout the rest of our talks today. And so these two diagrams show exactly what I just discussed. On the left, let me pull up my laser pointer. On the left-hand side, at extremely low mechanical index, we get a linear response of the microbubbles. At low MI, we begin to see these nonlinear responses that I just discussed. High MI, we begin to see microbubble destruction. And on the diagram on the right, we see one of the ways in which ultrasound machines offer this on-cart processing. Here we see the principle of amplitude modulation. We essentially, what we're doing is we're sending two subsequent pulses from the ultrasound probe with a twofold difference in amplitude. The same two pulses, when reflected by the tissue, are then used to cancel each other out. But when the same two pulses are reflected by the nonlinear microbubbles from each other, not only do they differ in amplitude, but they also differ in shape. And so these amplitudes are not able to cancel each other out, and you're left with this signal, or what we call the nonlinear reflection, and that is what we use to be able to improve our imaging quality and technique. Now, in subsequent talks, you'll hear more about the physics and the imaging process from Tom, but at this time, I'd kind of like to set the stage and focus more on the preclinical and clinical work that has been done over the years on myocardial contrast echocardiography and where we stand today. Now, as I mentioned, a lot of the initial evaluation was frequently done in the cath lab by pioneers like Dr. Feinstein and many, many others. But some of the most initial in vivo work in myocardial contrast echocardiography really began in assessing and defining the presence and size of the myocardium at risk during an acute coronary occlusion. And so that was the initial first steps, and then we subsequently began looking at reperfusion with these microbubbles as well as residual infarct size. And then finally, in initial and in vivo studies, it was used to assess the presence and extent of collateral perfusion during acute coronary occlusion and the influence that collaterals had on the myocardial viability. And so once scientists were confident in the ability of these ultrasound enhancement agents to predict infarct size in the preclinical world, then we really began moving into the clinical world. And so one of the original and most powerful studies showed that in patients presenting to the ER with chest pain and who had non-diagnostic EKGs, that myocardial contrast echo was more effective and predictive by as much as about 17% at predicting cardiac events, when compared to the combination of demographic data, clinical data, and risk factors or, pieces of clinical data such as troponin and EKGs. And this was really the first study that showed a significant clinical benefit that myocardial contrast echo could be used as a diagnostic tool that was really currently better than our standard practice of care at helping to diagnose patients with chest pain and evaluating for obstructive coronary disease. And so the other piece that came along with that was that others really began looking at the utility. So we knew it was a better tool, but how could we utilize this tool? And so others began looking at that and showing that in patients who had both a normal wall motion and normal myocardial perfusion, at 2 years out, their event-free survival rate, so, having an event, basically a heart attack or possibly even death, was much greater, and so they were having less events than those who had either abnormal wall motion or abnormal perfusion. So again, these studies were the initial clinical evaluations of myocardial contrast echocardiography, and they were profound. And so several subsequent authors evaluated